Okay, let's unpack this. We are diving into a really critical topic today. Acute coronary syndromes, ACS.
Yeah, ACS.
This is basically the fast track, right? Understanding how we recognize, diagnose, and crucially manage this major heart emergency. We want to move from, confusion to real clarity, especially when it's potentially life or death.
And our mission, especially for you listening, is absolute focus. We're not just like listing facts off a page. We're pulling out the really high stakes knowledge, the stuff you need to know right now, the things that guide your immediate actions and critical care. We'll break down diagnosis, the key interventions, and maybe most importantly, the priority teaching points and safety alerts for the essential meds.
Okay, so let's set the scene a bit. ACS is the crisis point. We're talking unstable angina and myocardial infarction, the heart attack. It's the acute flare-up, really, of long-standing coronary artery disease, CAD. And the core mechanism, it seems, is always the same thing happening inside the artery.
Right. Something breaks. Specifically, an atherosclerotic plaque ruptures inside the artery wall. And that rupture, well, it triggers the body's emergency response. Platelets rush in, things get sticky, and you end up with a thrombus, clogging the pipe.
So if we want to really anchor this understanding, what are the key concepts?
Okay, two foundational ideas. First, and honestly the most critical, is perfusion.
Perfusion.
Blood flow.
Exactly.
Yeah.
Impaired blood flow means ischemia. The tissue isn't getting enough oxygen, it's starving. And if that ischemia goes on too long...
When you get infarction.
Right, infarction. That's necrosis, cell death. Pretty much every single thing we're going to talk about today is aimed at stopping or limiting that terrible progression from ischemia to infarction.
Okay, perfusion is number one. What's number two?
The symptom that usually gets the patient's attention, the thing that brings them in, pain.
Angina.
That chest discomfort, angina pectoris. It's basically the sound the heart makes when its oxygen supply just can't keep up with the demand. It's a warning sign.
Right. So you mentioned CAD earlier. How does that fit in? It's all about context. CAD, coronary artery disease, is the chronic underlying issue. It's the slow buildup of those plaques, those blockages over years.
Okay.
ACS is the acute phase. It's that sudden explosive event when one of those plaques finally ruptures and perfusion is immediately severely compromised. It's like the slow burn suddenly turning into a 5-alarm fire.
Got it. So chronic problem leads to acute crisis.
So to really get a handle on this emergency, we kind of need to understand the slow disaster that came before it. The pathophysiology of atherosclerosis.
It's sneaky, isn't it? It starts with damage to the endothelium, that inner lining of the artery.
Yeah, often from things like high blood pressure, smoking, high cholesterol. Those insults damage the lining.
And then what happens?
Well, that damage attracts inflammatory cells. It's like a tiny wound. You start getting fatty streaks, which then kind of organize and harden into a fibrous plaque. Think of it like a scar forming.
Okay, a plaque.
But the real crisis, the ACS event, starts when that hard plaque, we call it a complicated lesion ruptures, like pops open.
You described it earlier like a pimple bursting inside the artery.
Exactly. And when it bursts, the stuff inside is exposed to the blood. The body sees that as an injury, so it triggers massive platelet aggregation. Platelets rush in, stick together, and form that thrombus, that clot.
And that clot is what causes the blockage.
Right. They can partially block the artery or sometimes totally block it.
And when that blockage gets really bad, like 80 or 90% reduction in flow, that's the heart attack, the MI.
That's the MI, myocardial infarction. It's injury and necrosis, tissue death because of severe oxygen deprivation. But, and this is crucial, how we manage it immediately depends entirely on how blocked that artery is.
Okay, so how do we know? How do we differentiate?
This is probably the single most important distinction you need to make right away because it dictates the entire treatment path. And the tool is the 12-lead ECG. Okay,
the ECG tells the story. Let's start with the maybe slightly less urgent one.
Right, let's talk non-ST segment elevation myocardial infarction, NSTEMI.
NSTEMI. What does the ECG show?
Typically, you'll see ST segment depression, or maybe T-wave changes, like inversion.
And what does that mean is happening in the heart?
It reflects myocardial ischemia. There's definitely damage happening. The heart muscle is injured, but the blockage is usually partial. Some blood is still getting through.
So it's serious, but maybe not quite as immediately catastrophic.
It's absolutely serious. The patient is unstable. But the priority is usually stabilization first, maybe some medications, and then getting them to angiography or PCI, but maybe not in the next 30 seconds. There's a window, often within 24 or 48 hours.
Okay, NSTEMI. AC depression, T-wave changes, partial blockage, ischemia focus, urgent but maybe not immediate reperfusion usually.
Exactly. Now contrast that with the absolute red flag, the code red, the ticking time bomb.
Which is
ST segment elevation, myocardial infarction, STEMI.
STEMI. And the ECG.
That's where you see the classic ST elevation. Sometimes it looks like a tombstone on the ECG strip. You need to see it in at least 2 contiguous leads, meaning leads looking at the same area of the heart.
And what does that signify?
When you see that ST elevation, you have to assume a 100% occlusion, total blockage. Acute necrosis, cell death is happening right now.
So no time to wait.
No time. This patient essentially bypasses some of the initial stabilization. The goal is immediate reperfusion, straight to the cath lab for PCI if possible, or initiating thrombolytic therapy, clot-busting drugs right away. The distinction and the urgency couldn't be clearer.
Okay, STEMA. ST elevation, total blockage, active necrosis, immediate reperfusion needed. Huge difference.
Massive.
So let's say the immediate crisis, the MI itself, is managed. Is the damage done, or does something else happen afterwards?
The damage doesn't just stop when the artery's opened. That leads us to the longer-term consequence, ventricular remodeling.
Remodeling, like construction?
Kind of, yeah, but not in a good way. See, infarction isn't instantaneous. It evolves over hours. You have different zones. In the center, the zone of necrosis, that tissue is dead, gone.
Okay.
Around that, there's a zone of injury. This tissue is damaged, but potentially salvageable if we get blood flow back quickly enough.
The goal of reperfusion.
Exactly. And then around that is the zone of ischemia, which is oxygen deprived, but likely to recover if perfusion is restored.
So what happens to the dead zone, the necrosis?
It gets replaced by scar tissue. And scar tissue is not heart muscle. It doesn't contract well. It doesn't conduct electrical signals properly. So the heart literally changes its size and shape, particularly the left ventricle, the main pumping chamber. That's ventricular remodeling.
And the consequence of that change in shape?
Mechanically, it means decreased left ventricular function. The pump is weaker. This leads directly down the path towards chronic heart failure.
Okay. Weaker pump. Any other issues?
Electrically, that scar tissue can disrupt the normal pathways, increasing the risk for dangerous, even lethal ventricular dysrhythmias later on.
And does it matter where the heart attack happens? Like which artery gets blocked? You hear about the widowmaker?
Absolutely. Location is critical. And yes, the widowmaker usually refers to the left anterior descending artery, the LAD.
Why is that one so bad?
Because the LAD supplies blood to the front wall, anterior wall, and the septum of the left ventricle. That's the powerhouse of the heart. So an LAD occlusion causes an anterior MI, which tends to damage a large critical area of the left ventricle.
And that means?
That means these MIs often have the highest mortality rate. You're knocking out the main engine.
Okay. What about other arteries, like the right coronary artery?
An RCA occlusion often affects the bottom inferior wall of the heart, and sometimes the right ventricle. Crucially, the RCA often supplies the heart's electrical nodes, the SA node, and the AV node.
So blocking the RCA might cause more rhythm problems.
Exactly. You're more likely to see things like bradycardia or heart blocks with an RCA occlusion. Still serious, but often the long-term impact on overall pump function might be less devastating than a big anterior MI from an LAD blockage, although complications can still be severe.
Okay, so if we want to prevent this whole cascade, we need to look way upstream at the risk factors.
Right. We know atherosclerosis is the main underlying cause, and the risk factors break down into non-modifiable things you can't change, like age, genetics, family history.
And the modifiable ones.
Yeah.
The ones we can actually do something about.
Yes. And there's one particular cluster of modifiable risks that's really important to recognize. It's called metabolic syndrome, or METS.
METS, I've heard it called like a silent bomb. Because it's not just one thing, it's several seemingly smaller issues adding up.
That's a great way to put it. It's having at least 3 out of 5 specific health problems that together dramatically increase your risk for cardiovascular disease, including ACS.
Okay, let's list them out. What are the 5 factors for METS? You do 3 of these.
Okay, number 1, the pressure, hypertension. Either a blood pressure reading of 130/85 or higher, or if the person is already taking medication for high blood pressure.
1.
Yeah. 2, the good cholesterol is too low. Decreased HDLC, that's less than 40 milligrams per deciliter for men, or less than 50 for women.
Okay, low good cholesterol. Number 3.
The fats are too high. Increased triglycerides, that's 150 milligrams per deciliter or higher, or if they're already on medication to lower cholesterol or triglycerides.
High triglycerides. 4.
The sugar is elevated. Increased fasting blood glucose, a level of 100 milligrams per deciliter or higher, or if they're taking medication for diabetes.
Okay, high fasting sugar. And the fifth one?
The fifth one is often the most visible, central obesity, basically carrying too much weight around the middle, measured by waist size 40 inches or more for men, 35 inches or more for women.
So hypertension, low HDL, high triglycerides, high fasting glucose, and central obesity. 3 out of 5 spells metabolic syndrome?
Right. And when you're educating patients, it's key to stress that these things often travel together, and improving one, like losing weight or increasing activity, can often help improve the others too. It's synergistic.
So patient education priorities really need to hammer these modifiable risks.
Absolutely. Top of the list, smoking and tobacco cessation. And you're right, that absolutely includes vaping. Non-negotiable.
Okay, what about diet?
Diet needs some precision. Limit dietary cholesterol to less than 200 milligrams a day. Sodium reduction is huge, aiming for less than 1,500 milligrams a day if possible. Saturated fats should only be about 5 to 6% of total calories. And trans fatty acids. Avoid them completely, just cut them out.
And activity.
We need to push for physical activity. The standard recommendation is moderate exercise. Think brisk walking 3 to 4 times a week for about 30 minutes. Even just advising a daily 30-minute walk is a great, achievable starting point for many people.
Now, beyond these individual choices, we also have to acknowledge the bigger picture, right? The structural factors, health equity disparities.
Yes, definitely. Our sources point out something really concerning. While overall death rates from coronary artery disease have gone down, which is good news,
Black.
but that decline has been significantly slower in Black populations compared to white populations.
Why is that?
It suggests complex, multifactorial issues. Things like unequal access to quality health care, delayed diagnosis, maybe less effective treatment plans being implemented consistently across different groups. Systemic issues.
Okay, that's crucial. What about gender differences?
Mm-hmm.
We used to hear about atypical symptoms in women.
We really need to move past that language.
Yeah.
The current thinking isn't that they're atypical, they're simply different manifestations of the same underlying problem, ischemia.
So women might experience heart attacks differently.
Yes. Many women who have symptomatic ischemic heart disease don't actually show those classic textbook findings on an angiogram, like a single big blockage.
Why not?
It might be related to having smaller coronary arteries on average, or sometimes instead of one big plaque rupture, maybe smaller bits of plaque break off and travel downstream, blocking smaller vessels. Microvascular disease.
So what kind of symptoms should we be looking for in female patients, especially symptoms that happen with exertion?
Things like profound, unusual fatigue, indigestion or upper abdominal pain, pain between the shoulder blades, shortness of breath, dizziness, palpitations, maybe even flu-like symptoms or just feeling off.
And the key is?
The key is, if a female patient presents with these symptoms, especially related to activity, you must consider cardiac ischemia until proven otherwise. Don't dismiss it as anxiety or indigestion just because it's not crushing chest pain radiating down the left arm.
Very important point. And are there other groups we need to consider regarding disparities?
Yes, the LGBTQ population. They often face increased cardiovascular risk factors, and this can be compounded by what's called minority stress, the chronic stress coming from stigma, discrimination, and prejudice.
So what's the implication for us as healthcare providers?
It means we need to be proactive and inclusive. We should respectfully ask about sexual orientation and gender identity as part of our assessment. This helps ensure we're providing equitable care, targeted risk screening, and relevant health promotion for everyone. It's about seeing the whole person and their unique stressors.
Okay, let's shift gears now. We're in the moment. The patient is symptomatic. They're having chest pain, or maybe those other symptoms we just discussed. What's the absolute priority?
Time is muscle, period. So rapid assessment is non-negotiable. If pain is the main complaint, you need to break it down quickly. Think PQRST.
PQRST. Onset, provocation, palliation, quality, radiation, severity, timing.
Exactly. When did it start? What makes it better or worse? What does it feel like? Squeezing, pressure, burning, tightness. Where is it? Does it go anywhere else? Jaw, back, shoulder, arm, even the stomach area. How bad is it on a 0 to 10 scale? And how long has it been going on?
Is there any particular type of pain that's more likely to be the heart?
Research suggests that left-sided squeezing chest pain has a higher probability of being actual ischemia. But you can't rely on that alone.
Okay. Now, you mentioned earlier the difference between angina and MI pain based on relief. Can you recap that? It seems critical.
Absolutely critical for your initial thinking. So, angina pain. Typically, substernal discomfort might radiate to the left arm. The key is it's usually relieved by rest or by taking nitroglycerin, NTG, and it usually lasts less than 15 minutes. Even unstable angina, which is more severe or frequent, generally follows this pattern of eventual relief.
Okay, angina gets better with rest or NTG. What about MI pain?
MI discomfort. This is usually more severe. Substernal pain or pressure, often radiating more widely left arm, jaw, back, shoulder, abdomen. The crucial difference: it's not usually relieved by rest or NTG, and it often lasts much longer, 30 minutes or more. That lack of relief tells you damage is likely occurring.
Unrelieved pain despite NTG suspect MI.
Pretty much. And the pain rarely comes alone, right? Those associated symptoms are often huge clues.
What should we be looking for besides pain?
Severe nausea, vomiting, profuse sweating diaphoresis, significant shortness of breath dyspnea, feeling really dizzy or lightheaded, crushing fatigue that comes on suddenly, feeling palpitations like the heart is racing or skipping, sometimes epigastric distress, feeling like bad indigestion.
And mental status changes.
Yes, definitely. Look for signs of anxiety, fear, maybe even disorientation or acute confusion, especially in older adults. That confusion might be the only sign.
Right, you mentioned older adults might present differently.
They often do. Patients over, say, 80 might delay seeking help because their symptoms aren't classic chest pain. They might just feel unwell or have sudden shortness of breath, indigestion, or that acute confusion or disorientation we talked about. It could be due to a drop in cardiac output affecting the brain.
So a high index of suspicion is needed for older adults with vague symptoms.
Absolutely. Silent MIs, or MIs presenting atypically, are common in this group and need aggressive treatment just the same.
Okay, patient arrives, possibly with these symptoms. What is the single most important diagnostic step that needs to happen immediately?
The 12-lead ECG. National guidelines are crystal clear. It needs to be obtained and interpreted within the first 10 minutes of the patient arriving at the emergency department if they have symptoms suggestive of an MI.
10 minutes. That's fast. The triage nurse is key here.
Absolutely critical role in making that happen.
While all this is happening, what about gathering history?
If the patient is actively symptomatic, you delay the non-urgent stuff. Focus on starting interventions, managing the pain, and getting only the most critical history right away, like what medications are they already on, do they smoke, any known heart problems, key risk factors. You can get the rest later once they're more stable.
Makes sense. What about blood tests?
The gold standard lab test for MI is checking cardiac biomarkers, specifically troponin T and troponin I.
Troponins. Why are they so specific?
Because these proteins are primarily found inside heart muscle cells. When those cells die due to lack of oxygen necrosis, the troponins leak out into the bloodstream. So elevated troponin levels are very specific indicators of cardiac muscle damage.
Do they rise immediately?
They rise fairly quickly within a few hours of injury, and they stay elevated for days. That's why we almost always draw serial troponins, meaning we check them multiple times over several hours, like at baseline, 3 hours, 6 hours. Seeing a rise and fall pattern confirms the diagnosis and helps understand the timing of the event.
Okay, ECG within 10 minutes. Serial troponins. What about the physical exam? What clues might we find?
You're looking for signs that the pump isn't working well, signs of decreased cardiac output. How does the skin feel? Is it cool, clammy, sweaty, diaphoretic? Are the peripheral pulses strong or weak, diminished?
Listening to the heart and lungs.
Crucial. Auscultate the heart sounds. Listen carefully for an S3 gallop. That extra heart sound often indicates the ventricle is stiff and struggling to handle the incoming blood volume, a common sign in heart failure. Also listen for any new murmurs, which could indicate a structural problem like papillary muscle rupture, a rare but serious complication.
And the lungs.
Listen for crackles or wheezes. Crackles, especially at the bases, usually suggest fluid backing up into the lungs from left-sided heart failure. Wheezes could also be heart failure, cardiac asthma, or sometimes bronchospasm.
What about signs of right-sided heart failure?
Check the neck veins for jugular venous distension, JVD. Look for swelling or peripheral edema in the legs and feet.
Okay. Anything else on physical assessment?
One slightly unusual thing, don't be surprised if the patient develops a low-grade fever, maybe up to 102 degrees AFR or 38.9 degrees C, a day or two after the MI.
A fever. Why?
It's an inflammatory response. The body is reacting to the necrotic, dead heart tissue. It's part of the cleanup process. All right, this is where the rubber meets the road. The patient is symptomatic. What do? The immediate goals are twofold. Stop the pain and, crucially, decrease the heart's workload, its oxygen demand, while trying to increase the oxygen supply, the perfusion.
Okay, sounds like a balancing act.
Yes.
Is there a standard protocol, like a checklist?
Most places have a chest pain protocol, but the core elements are universal. Think ABCs first. Assess airway, breathing, circulation. Be ready to defibrillate if they go into VFib or pulseless VTach.
Got it. ABCs, be ready for electricity.
2. Continuous ECG monitoring. You need eyes on that rhythm constantly. 3. Get a full set of vital signs immediately. BP, pulse, respirations, oxygen saturation.
Okay.
4. Activate the protocol, notify the provider or the rapid response team right away. 5. That crucial 12-lead ECG within 10 minutes. We can't stress that enough.
ECG in 10. Got it.
And 6. Start interventions for pain relief and administer aspirin as prescribed or per protocol.
Okay, that covers the immediate actions.
Yeah.
Let's talk about the common initial drug therapies. People often hear about MO&A.
Right. MO&A, morphine, oxygen, nitroglycerin, aspirin. It's a useful mnemonic, though the order and necessity might vary a bit now. But let's break down those key drugs, focusing hard on the nursing priorities and safety alerts.
Okay, let's start with nitroglycerin, NTG. How does it work?
NTG is a real workhorse. It does two main things. First, it dilates coronary arteries, which can help increase blood flow, especially collateral blood flow around a blockage.
Okay, opens up the heart's pipes.
Second, and maybe even more importantly, it causes peripheral vasodilation. It relaxes blood vessels throughout the body. This reduces the amount of blood returning to the heart, preload, and the pressure the heart has to pump against afterload.
So, less work for the struggling heart muscle.
Exactly. Decreases myocardial oxygen demand significantly.
Okay, how do we give it, and what do we need to teach the patient? This seems like priority teaching.
Absolutely. For the sublingual tablet, the little one that goes under the tongue, you must teach the patient not to swallow it. It needs to dissolve there for rapid absorption. There's also an NTG spray that works similarly.
How quickly should it work?
Pain relief should start within 1 to 2 minutes, and it should be pretty clear, hopefully gone, within 3 to 5 minutes.
What if their blood pressure drops? That vasodilation effect.
Huge nursing intervention point. You must monitor BP closely. If the systolic BP drops below 100 millimeter Hg, or if it drops more than 25 millimeter Hg from their previous reading, your immediate actions are lower the head of the bed to help blood flow to the brain and notify the provider immediately. Don't give more NTG until you check with them.
Okay, watch the BP like a hawk. Lower HOB. Call provider if it tanks. Is there anything else critical about NTG?
Yes, the hidden landmine. The absolute D-drug alert you cannot forget. NTG is absolutely contraindicated if the patient has recently taken phosphodiesterase inhibitors.
Those are the drugs for it.
Erectile dysfunction like sildenafil, Viagra, tadalafil, Cialis, vardenafil, Levitra, or sometimes for pulmonary arterial hypertension, you need to ask specifically, have you taken any medications for erectile dysfunction in the last 24 to 48 hours?
Why is this combination so dangerous?
Because both drugs are potent vasodilators. Giving them together causes an additive effect, leading to potentially profound, irreversible hypotension. The patient can go into shock and die. It's that serious. You must ask.
No. Okay, crucial safety point. Ask about ED meds before giving NTG. What if the pain doesn't go away after NTG? You usually give it up to 3 times, right?
Right. Typically 1 tablet or spray every 5 minutes, up to 3 doses. If the pain persists after the 3rd dose, you have to assume it's an MI, not just angina, and move on to stronger measures and the definitive MI plan.
Okay, so if NTG doesn't cut it, what's next for pain? Usually morphine sulfate.
Yes. If the discomfort is unresponsive to NTG, morphine is the next step. It's obviously a powerful pain reliever, but it also has other benefits in this situation.
Like what?
It helps relax smooth muscle, which can cause some vasodilation too, further reducing preload and afterload. And importantly, it helps reduce anxiety and can decrease the levels of circulating catecholamines, those stress hormones like adrenaline, that are whipping the heart harder.
So it calms the patient and the heart. How is it given?
Morphine is a high-alert drug. It's usually given slowly, IV push, often in small doses like 2 to 4 milligrams, repeated every 5 to 15 minutes until the pain is relieved or side effects occur.
And what are those side effects we need to monitor for?
The big ones. Respiratory depression, watch their breathing rate and depth. Hypotension, monitor BP closely. Bradycardia, watch the heart rate. And nausea or vomiting are also common.
Okay, slow IV push, watch respirations, BP, heart rate, and be ready for nausea. What about oxygen, part of MONA?
Oxygen used to be given routinely to everyone with chest pain. The guidelines have shifted a bit. Now, we generally only administer supplemental oxygen if the patient's oxygen saturation is less than 90%.
So not automatically anymore.
Not automatically if their saturation is normal. But if they are hypoxemic, set BO2 90%, then yes, absolutely give oxygen, usually 2 to 4 liters per minute via nasal cannula, aiming to keep the saturation at 90% or higher.
Why only if they're low? Isn't more oxygen always better for a struggling heart?
That's the controversy. Some studies suggested that giving high-flow oxygen to patients who aren't hypoxemic might actually cause coronary vasoconstriction and potentially worsen outcomes. So the current practice is more targeted. Treat hypoxemia if it's present.
Okay, O2 if SpO2 90%. Now, let's talk about stopping that clot from getting bigger or new ones from forming. Antiplatelet therapy.
Yes, absolutely vital. The first immediate step is aspirin, ASA. The American Heart Association and American College of Cardiology recommend giving 325 milligrams of non-enteric-coated aspirin immediately, and the patient should chew it.
Chew it. Why chew?
Chewing breaks it down faster and allows for quicker absorption through the mucous membranes in the mouth, getting it into the system faster than swallowing it whole.
And what does aspirin do?
It inhibits platelet aggregation, makes platelets less sticky, and also has some anti-vasoconstriction effects. It's a cornerstone therapy and usually continued lifelong after an ACS event.
Okay, chew 325 milligram aspirin immediately. What comes after aspirin? Often another antiplatelet.
Yes, typically we move to dual antiplatelet therapy, or DAPT. This means adding a P2Y12 inhibitor along with the aspirin. Common examples are clopidogrel, Plavix, ticagrelor, Brilinta, or prasugrel, Effient.
And how long do patients stay on DAPT?
It depends on the situation, like if they got a stent, but often it's continued for up to 12 months after the ACS diagnosis.
What's the main nursing concern with the DDT?
Bleeding. You've got 2 drugs working to stop platelets from clotting. So a nursing priority is constant vigilance for bleeding. Teach the patient and family to report any unusual bruising, nosebleeds, blood in the urine or stool, which might look black and tarry, or any bleeding that doesn't stop easily.
Okay, DAPT equals heightened bleeding risk. Watch and teach. Are there even stronger antiplatelet drugs?
Yes, for higher risk situations like patients with NSTEMI or unstable angina going for PCI, we might use intravenous glycoprotein, GPIOBA inhibitors. Examples are eptifibatide, integralin, or tirafiban, aggrastat.
How do they work?
They are very potent. They work later in the clotting cascade by blocking the final common pathway for platelet aggregation, preventing fibrinogen from linking platelets together.
Sounds powerful. What are the nursing priorities for these 5E drugs?
Even higher bleeding risk here. So assess closely for any bleeding or signs of hypersensitivity reaction, and critically, you must monitor their platelet count. Platelets should be checked about 4 hours after starting the infusion and then daily. If the platelet count drops significantly, thrombocytopenia, it's an emergency. Stop the infusion and notify the cardiologist immediately. It could be heparin-induced thrombocytopenia, HIT, if they're also on heparin, or drug-induced thrombocytopenia.
Okay. GPIMA-IBA inhibitors, potent IV, watch for bleeding, check platelets frequently. Now, shifting gears slightly, drugs to protect the heart muscle itself. Beta blockers, BVs.
Yes. Beta blockers are crucial. Drugs like metoprolol, especially the long-acting XL form or carbidool CR, these are often cardioselective, meaning they primarily target beta-1 receptors in the heart.
What's the goal of using beta blockers after an MI?
They slow the heart rate and decrease the force of the heart's contraction, negative chronotropy and inotropy. This significantly reduces the workload on the heart and its oxygen consumption. It gives the injured heart muscle a chance to rest and heal. They've been shown to reduce mortality, particularly in patients who develop heart failure symptoms after their MI.
So pretty much standard practice unless there's a reason not to give them.
Exactly. Most NSTEMI and STEMI patients should be started on a beta blocker within 24 hours, unless contraindicated.
What are the contraindications? This sounds like another major safety alert.
It absolutely is. The non-negotiable stop sign for giving a beta blocker is pulse below 50 beats per minute or systolic blood pressure below 100 millimeter Hg. If you see either of those numbers, you must hold the dose and check with the provider first.
Why is that so critical?
Because if the heart is already struggling, low rate or low pressure, giving a beta blocker could slow it down or weaken it even further, potentially leading to dangerous cardiogenic shock or worsening heart failure.
Okay, Holby, if HR50 or SBP100, what else do we monitor for?
Besides bradycardia and hypotension, watch for decreased level of consciousness, which could indicate poor brain perfusion. Also, listen to the lungs carefully before and after giving the dose. Check for new crackles or wheezes, which could signal worsening heart failure or, especially with non-selective beta blockers, bronchoconstriction in patients with asthma or COPD.
Got it. Beta blockers are good, but require careful monitoring and have clear stop parameters. Are there other essential long-term meds started early?
Yes, two more key classes. First, ACE inhibitors like lisinopril or ARBs like losartan.
Angiotensin-converting enzyme inhibitors or angiotensin the secondary receptor blockers? Why are they used post-MI?
They are started within 24 hours if possible, primarily to prevent that negative ventricular remodeling we talked about earlier. They help stop the heart from changing shape in detrimental ways, and they are very effective at preventing the development or progression of heart failure.
What do we monitor with ACEs and ARBs?
Monitor blood pressure for hypotension, check kidney function, BUN, creatinine, and potassium levels, and specifically for ACE inhibitors, watch for that persistent dry cough, which can be a common side effect requiring a switch to an ARB. Also, monitor for decreased urine output, which could signal kidney issues or worsening heart failure.
Okay, ACE-ARBs for remodeling and heart failure prevention. What's the last major drug class?
Statins. High-intensity statin therapy like atorvastatin Lipitor 80 mg or rosuvastatin Crestor 20-40 mg should be started for basically all patients diagnosed with ACS, regardless of their baseline cholesterol levels, unless contraindicated.
Why high intensity for everyone?
Because we now know statins do more than just lower cholesterol. They also have anti-inflammatory effects and help stabilize existing plaques, making them less likely to rupture again. Starting high-intensity statin therapy post-ACS significantly reduces the risk of recurrent MI, stroke, and death. It's fundamental secondary prevention.
Okay, so we've stabilized the patient with meds, managed pain, start antiplatelets and anticoagulants. But for the patient with a STEMI, that 100% blockage, the ultimate goal is reperfusion. We have to get that artery open again fast.
Restore the blood flow, limit the damage, salvage the muscle.
Exactly. That's the entire game for STEMI.
What's the preferred method for reperfusion?
For most patients with STEMI, the gold standard, the treatment of choice, is percutaneous coronary intervention or PCI.
PCI, that's angioplasty and stenting, right? Going in with a catheter.
Correct. It's a non-surgical procedure where they thread a catheter, usually through the wrist, radial artery, or groin, the femoral artery, up to the blocked coronary artery.
And this needs to happen quickly for STEMI. Extremely quickly. This is where that time is muscle mantra really hits home. The national goal is door-to-balloon time of 90 minutes or less. That means from the moment the patient hits the hospital door to the moment the balloon is inflated in the blocked artery should ideally be under 90 minutes.
Wow, 90 minutes. That requires incredible coordination.
It does. The emergency department, the cath lab team, cardiology, everyone has to work seamlessly. Once the catheter is at the blockage, they inflate a small balloon on its tip. This compresses the plaque against the artery wall, opening up the vessel.
And then they usually place a stent.
Yes, almost always. After the balloon opens the artery, they deploy a stent, a tiny expandable mesh tube to act like scaffolding and keep the artery propped open long term. Stents can be bare metal or, more commonly now, drug-eluting, meaning they slowly release medication to prevent scar tissue from building up inside the stent.
Okay, so PCI within 90 minutes is plan A for STEMI. What if a hospital can't do PCI quickly? Maybe a rural hospital without a cath lab or transport time is too long.
That's where plan B comes in. Thrombolytic therapy, also called fibrinolytic therapy.
Thrombolytics, the clot busters.
Exactly. These are powerful intravenous drugs designed to actively dissolve the thrombus, the clot that's blocking the artery, and restore blood flow that way.
Who gets thrombolytics?
They are specifically for STEMI patients who cannot get timely PCI within that 90-120-minute window, depending on transfer time. It's crucial to remember, thrombolytics are not indicated for NSTEMI or unstable angina, only for STEMI with ongoing symptoms when PCI isn't an immediate option.
Is there a time goal for giving thrombolytics?
Yes. The goal is door-to-needle time of 30 minutes or less. Get that clot-busting drug infused within 30 minutes of the patient arriving and STEMI being confirmed on the ECG.
Okay, 30 minutes for thrombolytics if PCI isn't happening fast enough. What are some examples of these drugs?
Common ones include tissue plasminogen activator, TPA, alteplase, retepilase, RPA, and tenecteplase, TNKs.
Now, dissolving clots sounds effective, but also risky. Bleeding must be a huge concern.
Massive concern. Because these drugs don't just dissolve the bad clot in the coronary artery, they interfere with clotting everywhere in the body. So you absolutely must know the contraindications. Giving a thrombolytic to the wrong patient can lead to catastrophic bleeding, especially intracranial hemorrhage.
Okay, this sounds like something we need to memorize. What are the absolute contraindications for thrombolytic therapy?
Think major bleeding risks, especially in the head or recent trauma surgery. The big ones are any history of prior intracranial hemorrhage, bleeding in the brain, ever.
Okay, previous brain bleed is out.
Known structural problems in the brain's blood vessels, like an arteriovenous malformation, AVM,
Got it. Abnormal brain
a
vessels.
known malignant brain tumor.
Brain cancer, out.
Ischemic stroke within the last 3 months, unless it was an acute stroke happening right now, within the very narrow 3-hour window where TPA might be used for the stroke itself. But generally, recent stroke is a contraindication.
Okay, recent stroke.
Suspected aortic dissection, a tear in the aorta, that's a surgical emergency, and thrombolytics could be fatal.
Aortic dissection, definite no.
Active bleeding currently happening, other than menstruation, or having a known bleeding disorder,
Active bleed, out.
and significant closed head trauma or facial trauma within the past 3 months, or major surgery within recent weeks.
Okay, recent major trauma or surgery, that's a critical list to know.
Absolutely non-negotiable. You screen carefully for every single one.
So, if the patient is eligible and receives thrombolytics, what's the nursing safety priority during and after the infusion?
Bleeding, bleeding, bleeding. Monitor constantly. Report any signs immediately oozing from IV sites, nosebleeds, blood in urine or stool, bruising.
What about internal bleeding?
You need to be hypervigilant for signs of internal bleeding. Monitor their vital signs closely for tachycardia and hypotension. Watch their hemoglobin and hematocrit levels for a drop. Test any stool, urine, or emesis for occult blood.
And the biggest fear, bleeding in the brain.
Yes. That's why frequent neurologic checks are essential. Document their level of consciousness, pupil response, motor function. Any change, headache, confusion, dizziness, weakness could signal an intracranial bleed and needs immediate investigation.
Okay, intense monitoring for any and all signs of bleeding, especially neuro changes. Now, after reperfusion, whether it was PCI or thrombolytics, does the patient still need medication to prevent new clots?
Oh, absolutely. Reperfusion is just the first step. Preventing reocclusion is critical. Patients who've received either PCI, especially with a stent, or thrombolytics will typically be maintained on therapeutic anticoagulation.
Anticoagulation like heparin.
Yes, often with heparin initially. It might be unfractionated heparin given as a continuous IV infusion, or sometimes low molecular weight heparin, LMWH, like enoxaparin, Lovenox, given subcutaneously. This is usually given concurrently with aspirin and often a P2Y12 inhibitor as well, DAPT.
What's the goal when using an unfractionated heparin infusion? Is there a lab value we monitor?
Yes, for unfractionated heparin, the goal is to keep the activated partial thromboplastin time, APTT, within a specific therapeutic range. This range can vary slightly by hospital lab, but it's typically aimed somewhere between 50 and 70 seconds. You need frequent lab draws to monitor the APTT and adjust the heparin infusion rate accordingly to keep it in that target zone, not too low, risk of clotting, and not too high, risk of bleeding. Heparin is another high alert medication requiring careful protocols. #tag outro, final takeaways, and provocative thought.
Wow, okay, that was quite the deep dive into the acute side of cardiology. A lot to process, but incredibly important.
It really is. The speed and accuracy of response makes such a difference.
So just to recap some key nuggets, we really hammered the difference between STEMI with that ST elevation red flag demanding immediate reperfusion and NSTEMI. Still urgent, but often a different initial path.
Right. And that absolute 10-minute window for getting the initial ECG, that's a system goal everyone needs to own.
And those critical drug safety points, holding the beta blockers if the heart rate or blood pressure is too low, that's non-negotiable.
Absolutely. And never, ever giving NTG without asking about recent use of those PDE5 inhibitors like Viagra or Cialis. That contraindication saves lives.
If you had to boil down the sequence for the symptomatic patient, what's the essential takeaway?
Okay, if I had to pick one flow, patient presents symptomatic, rapid assessment, PQRST, vitals. Makes ECG within 10 minutes, give chewed aspirin, give NTG up to 3 doses, 5 minutes apart, checking for PD5 use first, monitoring BP. If pain persists or STEMI confirmed, activate reperfusion strategy immediately. PCI goal 90-minute, thrombolytics goal 30-minute, PCI delayed. all while continuously monitoring ECG, vital signs, and watching vigilantly for complications like bleeding or ventricular dysrhythmias, which are super common in those first few hours after MI.
That really connects all the dots. And the thread running through everything we discussed, from diagnosis to every single intervention, seems to be
Perfusion. It all comes back to restoring and maintaining blood flow to that heart muscle as quickly and safely as possible. Every diagnostic test, every drug, every procedure is ultimately aimed at improving perfusion to limit damage and preserve function. Time is muscle, and preserving muscle means preserving life and quality of life.
right. Which brings us to a final thought. We talked quite a bit about how infarction, that cell death, leads to scar tissue and that long-term negative ventricular remodeling, which causes chronic problems like heart failure down the road.
Yeah, the long-term consequences.
So here's something to think about. Considering how damaging that remodeling process is, how exactly does timely reperfusion, getting that artery open within that golden window, especially the first 4 to 6 hours, actually change the physical shape and the future mechanical function of that patient's heart? How much remodeling can we actually prevent with speed?
That's a fantastic question. It really highlights the profound link between the critical care interventions you perform in those first few hours and the patient's entire cardiovascular future, potentially years or decades later. It's not just about surviving the acute event, it's about shaping the long-term health of their heart.